Olá, bem-vindo a todos. Eu sou o Paulo Renato, eu sou o coordenador da Clínica de Dor do Programa de Gerenciamento de Dor do Américas Oncologia Rio de Janeiro. A partir de agora, apresentarei os nossos palestrantes que falarão em inglês e nós teremos tradução simultânea. Hi, I would like to introduce Professor Marcelo Sousa. He is the CEO of Bright Photomedicine, and Professor Michael Hamblin, ex-professor of Harvard University, United States, and a professor visiting Joanesburgo University. Thank you, Marcelo. Welcome. Tell me about the pharmaceutical and laser and LED photoceutic medication. Thank you very much for coming.
Yes, actually, I would like to start saying that I'm really grateful to stay here with you. It's really important to have that type of meetings and connections and to make that type of knowledge available for physicians. So great, it is really great to stay here. And I have the pleasure to invite for the conversation my advisor during my PhD at Harvard Medical School, probably the greatest name in fotobiomodulation therapy in the world, and a very important scientist. And he is Dr. Michael Hamblin. And besides to be so important for the history of photobiomodulation, he also is very humble and accepted that invitation really quickly and is here to talk to us. So I would like to say one more time, thanks for Dr. Hamblin, and please make your presentation about photobiomodulation. After that, I will have the challenge to make my presentation after him. And we go for a nice talk for sure about that very interesting field. So please, Dr. Hamblin, make your presentation. Thank you very much.
Unmuted, so you should be able to hear that. No, it's not that one. So can you all see that?
Yes, we can see it.
Okay, right. Let me get stuck into this. So thanks for the introduction, Marcelo. Talk today is about the sort of history, mechanisms, and applications of photobiomodulation. I have a little outline. I'll talk about, as I say, history, mechanisms, devices, and applications, and some of the clinical applications. So the history of PBM is 120 years old when Niels Finsen won the Nobel Prize in 1903. And he actually died just 1 year after he won the prize because he had Niemann-Pick's disease. And he had found that going out in the sunshine helped his disease, and this motivated him to study light therapy. And he built a famous Finsen lamp, which was quite an undertaking. And as time went on, because winning a Nobel Prize is quite a big deal, other people took up this idea of light therapy. And in those days, you know, was fairly not advanced types of light. Basically, a lot of it was electric light bars. And John Harvey Kellogg, the same guy that introduced Kellogg's cornflakes, was a big mover. He had all these electric light baths and treated various diseases and conditions. And then a little while later, Auguste Rollier set up heliotherapy clinics in the Alps, and all sorts of people traveled to his clinics to be exposed to sunshine up in the mountains. And he said he thought it was the temperature, he wanted cold temperature to have a proper treatment, But it's probably more that the lack of oxygen in the mountains made the thing rather than the cold temperature. Moving forward, and Albert Einstein, as everybody knows, first proposed the phenomenon of stimulated emission and population inversion. But it took quite a long time until 1960 before Ted Mayman built the first working laser, which was a flash lamp pumped ruby laser. Soon after that, Paul McGuff, actually in Boston, got a ruby laser and he treated some tumors because it was a newfangled thing. And he managed to cure some cancers with this ruby laser. Over in Hungary, Andre Mester also got an interest in this, and he got a ruby laser. He attempted to repeat Paul McGuff's anti-tumor treatment, but his laser wasn't as powerful as Paul McGuff's laser, so it failed to cure any tumors, but then he tried to see if it could cause skin cancer in mice. He didn't cause any skin cancer either, but he did observe increased hair growth and stimulated wound healing, but no cancer. So this triggered a lot of interest in what was called low-level laser therapy then, because this idea you could use light to stimulate healing and relieve pain and inflammation really caught on. And after all these funny names, which makes it difficult to search the old literature, we have settled on photobiomodulation as the new consensus term. But you notice that a lot of these have got low because a little light is better than a lot of light. So there's a biphasic dose response in photobiomodulation, where you increase the light dose, the effect gets better. If you keep increasing the light dose, the effect goes away. So you have to be careful to use the right amount of light. What color light to use? Well, there's this thing called the tissue optical window, because there are chromophores in tissue that prevent the light getting in, and that best penetration is in this area between 600 and 1200 nanometers. So this is the tissue optical window, and people use lasers and LEDs in the red and near infrared. Now the mechanisms, the most popular mechanism involves the mitochondria, and here you see the respiratory chain in the mitochondria with the electrons hopping along until finally you get ATP formed from ADP. The mitochondria, as you all know, the source of the biological energy fuel, which is ATP. And a popular theory is that unit 4 in the mitochondrial respiratory chain, called cytochrome C oxidase, can be inhibited by nitric oxide, and the light can kick out this inhibitory nitric oxide, allowing oxygen to go back in and speed up the electron transport. You get more oxygen consumption, raise the mitochondrial membrane potential, get more ATP. You get a brief burst of reactive oxygen species, which I will talk about later. And also you get changes in calcium, which again, I'll talk about later. So, you know, a brief exposure to light can cause biological effects that last for hours, days, or even weeks after a single exposure to light. So the only way to explain this is that you are triggering transcription factors, and transcription factors cause gene expression, you get more proteins formed. And this could happen via the ROS, because there are ROS-sensitive transcription factors. It can happen via the ATP and cyclic AMP, because there's June phos as a transcription factor, but also the nitric oxide that you get can also carry out signaling. So there are all these signaling pathways that can be activated by photobiomodulation and cause long-lasting changes in the tissue. However, these mitochondria and cytochrome C oxidase it became clear it wasn't the only chromophore, because wavelengths like 980 and even longer near-infrared wavelengths are not absorbed by cytochrome C oxidase, so they must be doing something else. And it's becoming clear that one of the things that they are doing is activated these light and heat-gated ion channels, so-called transient receptor potential ion channels, the whole family of them here. But for the photobiomodulation, the TRPV, transient receptor potential vanilloid. Now, TRPV1 is the receptor for capsaicin and hot chili peppers, but it also can be activated by near-infrared and infrared wavelengths, but also by blue-green light, interestingly. So here we see the TRP ion channels can either be activated by blue-green light via opsons, or else by infrared light, because it's absorbed by nanostructured water. You get a conformational change in the protein due to nanoscale heating of the water. But it's not measurable heating, it's all on a nanoscale. And both of these open these ion channels and let calcium through, and they can be in the plasma membrane, but they can also be in the mitochondrial membrane. And again, you get transcription factor activation. A couple of other possible mechanisms I'll mention briefly. One is that the interfacial water that is in the mitochondria, the viscosity can be decreased by absorption of various wavelengths of light. And you get this molecular rotor, ATP synthase, whizzes around faster and produces more ATP. And the last mechanism I'll just mention briefly is you could get direct excitation of oxygen to form singlet oxygen. Here is the absorption spectrum of oxygen, and you see that there are peaks at 1063 and 1270. So lasers at these wavelengths have been shown to produce singlet oxygen directly from oxygen, and this can have biological effects. So several possible mechanisms to explain the PBM effects. It was recently reported that blood contains circulating cell-free mitochondria, which was quite a discovery. Nobody had realized that before, because one thing we want to explain is why there's a systemic effect of photobiomodulation. In other words, why we can shine the light on one part of the body and have effects at distant organs that don't get any direct light. Well, there's some kind of circulating mediator that can take the message from where you shine the light to distant organs. So this was one hypothesis showing that why normal cells do not respond in a major way to photobiomodulation. The idea was that if the nitric oxide was inhibiting the mitochondria, these cells would respond. But in normal cells where there's no inhibition, they respond a bit, but nowhere near as much as damaged or hypoxic cells. I'll mention briefly some studies. This is a study we did a while ago that shows that you can activate NF-kappa B by reactive oxygen species with what we call low-level laser therapy. Then it was 810 nanometer laser. And you see that you get very similar activation of NF-kappa B as you would with lipopolysaccharide, which is a classical way to activate NF-kappa B. And here's some Western blots showing that you get more phosphorylated NF-kappa B with laser. There's a lot of molecules in the body whose job is to sense reactive oxygen species and carry out signaling, mainly to protect organisms against the damaging effect of ROS. So ROS is a classical Janus molecule. A lot is damaging, but a little bit of ROS is actually beneficial. That's one reason why aerobic exercise is good for you, because you're producing brief bursts of reactive oxygen species. There's a lot of NF-kappa B target genes, a lot of anti-apoptotic proteins, antioxidant proteins, cytokines, pro-proliferation, pro-inflammatory, adaptive immunity, acute phase responses. NF-kappa B is a highly pleiotropic signaling molecule. So this is showing the biphasic dose response in vitro in cultured primary cortical neurons. And you see that both for intracellular calcium, for mitochondrial membrane potential, there's a peak, 3 joules per square centimeter. You increase the dose, it goes down. But you see that for ROS, there's a double peak. There's a peak at 3 joules, which corresponds with these peaks, but there's also a peak at 30 joules. So what we think is that this burst of ROS is beneficial, but this burst of ROS is damaging, and it's probably different ROS, right? You know, hydroxyl radicals are damaging, but superoxide can be good in small quantities. Again, this shows this idea that in normal cells, you get a burst of ROS here and here, but when you give the cells oxidative stress with cobalt chloride, with hydrogen peroxide, or with rotenone, the photobiomodulation reduces the ROS. And with mitochondrial membrane potential, it goes up each time. So the idea here is that when cells are under oxidative stress, their mitochondrial membrane potential is lower, and the light brings it back to normal, and this reduces the ROS. So although in normal cells you create ROS, in cells under oxidative stress, you reduce ROS because the mitochondrial membrane potential is raised in all cases. This is a similar study showing that you get, if you look at the viability, it goes up because we know it increases the viability. At the ATP, it goes up even when it's damaged by excitotoxicity. So how do we reconcile the fact that you increase NF-kappa B, which is a well-known pro-inflammatory transcription factor, but we all know that PBM is anti-inflammatory? And the answer to this is that in the normal fibroblasts, they're not activated, but in activated inflammatory cells are different. And here we show that because we have bone marrow-derived dendritic cells, and if we activate them with this LPS or with CPG, these are toll-like receptor agonists, we can reduce the inflammatory effects with the photobiomodulation. So in normal cells, you activate NF-kappa B, but in activated cells, you can deactivate NF-kappa B. So it appears to be a paradox. It's like the ROS, but when you think about it, it's actually not a paradox. Again, why should PBM be anti-inflammatory? Praveen Arani has shown you can activate TGF-beta. It's known that you can change the polarization of monocyte macrophages from M1 to M2. Pro-inflammatory cytokines go down, anti-inflammatory cytokines go up, and as we've shown, oxidative stress is reduced. Now, this switching the mitochondrial metabolism from glycolysis into oxidative phosphorylation has two important effects. So stem cells in their hypoxic niche carry out glycolysis, but when their mitochondria are activated, they leave their niche in search of oxygen because they need to do oxidative phosphorylation. And this activates proliferation and differentiation programs in stem cells. These M1 macrophages also carry out glycolysis. So when oxidative phosphorylation is activated, they switch to the M2 anti-inflammatory phenotype. And if this happens in the brain with microglia, these M2 phenotype can carry out phagocytosis and like remove amyloid plaques. So PBM, as you all know, is used all over the body for all kinds of different diseases and conditions. So, you know, a lot of them are serious conditions internally. It's somewhat difficult to get the light in, but lung inflammation, heart attack, kidney failure, bone marrow to activate stem cells, more superficial things. Dentists like it, oral mucositis, skin rejuvenation, good for the eyes in ophthalmology, good for the ears. A lot of pain, lower back pain, carpal tunnel syndrome, muscle fatigue, all over the body, from the top of the head to the tips of the toes. So it's just a matter of applying the right kind of light to the right part of the body. So looking at some devices that people have used, a lot of people like lasers. These are high power lasers, which are quite expensive. But, you know, you can expand the beam and deliver quite large amounts of light over large areas. When I say large amounts of light, I'm talking about thousands of joules, possibly in some cases even tens of thousands of joules of total energy. Another way of doing that is with whole body photobiomodulation, because like the Novo Thor is 1,000 watts of optical power, so it can deliver hundreds of thousands of joules of energy to the body. And there's various other big panels and light beds. So this is becoming quite a popular way to deliver photobiomodulation. There's a lot of home use devices based on LEDs. I mean, one advantage of LEDs over lasers is there's no safety concerns. So you can sell them and you can't do any damage with them. And LEDs have been approved as safe by the FDA, which doesn't mean they've been approved for treating diseases, but they've been approved for general health and wellness applications. So you can sell them. Some of them are flexible. You can wrap around various parts of the body. Some little handheld devices. So in my opinion, these are probably the future of PBM as home use devices, because it's been difficult to get large-scale clinical approvals for treating diseases because the trials are too expensive for the companies. I'll tell you a little bit about photobiomodulation for the brain, which is one of my areas of interest. There's been all sorts of helmets and various devices published to put light into the head. Some better ones are not even shown here, but you know, a lot of people are interested in applications for brain disorders. So I'm sure these devices will keep being produced and tested. My lab did a lot of studies on traumatic brain injury in mice. I won't present them all in detail. You can look them up. They're listed here. We showed that you could increase the cognitive performance of brain-damaged mice. You could increase BDNF. You could increase synaptic plasticity. You could increase neuroprogenitor cells. All of these are critically important in the brain. There are multiple mechanisms of PBM in the brain, and here's the neurotrophins, the neurogenesis, the synaptogenesis, but you get angiogenesis in a brain injury, you get anti-apoptosis, you get antioxidants, you get increased blood flow, you get increased lymphatic drainage, so less edema. So many different ways that the light can benefit the brain. And this has led to people studying photobiomodulation for a huge range of brain disorders. So there's traumatic ones like stroke, TBI, global ischemia, birth trauma. Some people have even tried to bring people out of a coma. There's neurodevelopmental disorders, autism, ADHD, Down syndrome, a lot of neurodegenerative diseases, Alzheimer's, Parkinson's, ALS, various kinds of dementia, CTE, which sports players get, Creutzfeldt-Jakob, Huntington's disease, and then a whole bunch of psychiatric disorders, depression, suicide, anxiety, PTSD, drug addiction, insomnia, and even sexual dysfunction. They've all been shown to be benefited by shining near-infrared light on the head. So, conclusions. Photomedicine has a 120-year history. The PBM mechanisms are becoming increasingly understood, although there's probably still some work to go on that. Both lasers and home-use LED devices are now available. PBM for brain disorders is a rapidly growing field. It's been found to be extremely safe with virtually no side effects. You really have to look hard to find any side effects from PBM. And as more clinical trials are carried out, it will undoubtedly lead to more regulatory approvals. So that's my lot. Here's the acknowledgements. It's a while ago that I had my lab, but here's a picture of the last time. And thank you all for listening.
Mike, thank you very much. Every time that I listen to you, it's a lot of new things. You are probably the only person in the world that can make me have the desire to come back to the PhD. But very, very interesting. But I will resist because we are having a good time in making some progress in the photobiomodulation by the side of the technology and the digitalization. And that is what I will present now. And I think that I can be quick in order to have a good conversation with you, that I really believe that is the most important part here is the it's a thing that it's a good, always a good opportunity. So I will share my presentation. I think I can be really quick. Let me see. Maybe it's better just share the whole screen. Okay, probably you are seeing my presentation now. I let it written in Portuguese, but of course I will present it in English. And today I will talk about photoceuticals. That is the name of the technology that use photobiomodulation therapy connected with digital therapeutics that usually is known as digiceuticals or software as a medical device. We focused on pain. 1 out of 3 people in the world suffer with chronic pain, but only 1 out of 4 have the right treatment. And many of them cannot afford a surgery or cannot do the surgery, even if they have the means to. So we are facing the world a big problem, not only in the difficulty to access the medicines, but also the addiction caused by that type of medicine, by Oxycontin and other types of drugs, painkillers like that. So that's one of the big issues that we can solve with photobiomodulation. The mechanisms of pain, as the physicians here know much better than me, is that you have some X stimulus that makes the body release substances that are stimulate the nociception, that that signaling of pain goes to the spine, and from the spine to the central nervous system. When I was with Mike Hamblin labs, we developed a way to shine light, but not only shine light in a way that are not precise, but in a way that we could find the very specific amount of light for each part of for different parts of the body of the animal. I will present here a little piece of that big puzzle, but only to make a point here that when we use the very specific amount of light, we can find different increase in ATP, as he talked before. Here we see an increase of 90% of free ATP. And we could find different biomarkers, different substances that were promoted, that release by the photobiomodulation. So it brings us the question, how to make photobiomodulation predictable, how to make it work for humans, not only for mice. And I believe that it was the biggest gap that makes photobiomodulation do not be mainstream today, because it is very hard to make the results of photobiomodulation predictable. So we glue it together around the photoceuticals, the methodology of the pharmaceutical industry, the software as a medical devices, and digital therapy to find specific characteristics of the patient with a huge amount of data, and the traditional ways to validate medicines, like the clinical trials, for example, to make it happen. It is very, very safe, as Mike told, and basically it can work for pain, inflammation, tissue regeneration, and neuromodulation, modulation of the immune system. But here we are talking much more about pain. And we found out that the dosimetry, when it is personalized, we can make it to induce the body to produce very specific substances. And some of that substances are anti-inflammatory and also are painkillers, natural painkillers that our body produce. It has no pain, it does not cause cancer, it has no side effect at all, as Mike told, and it's as we use 120 centimeters each time with a power of 7.2 watts of power. That makes in 5 to 10 minutes thousands of joules of applications. We deliver a huge amount of light, but in a very precise way, in a very specific spots of the body that will increase the production of ATP, so the cells will have the right amount of ATP to produce their own medicines, so the endogenous medicines. To solve that problem of personalization, we developed a software that can take into account the color of the skin of the patient, the gender, the tissue, the thickness of the fat tissue, and the level of pain during that application. So we use all of that to calculate a customized dosimetry for that person in that exactly moment. So in some way, it's like we have the best scientists, physicians, and physicists working together with the intelligence to make the very precise dose for that patient in that moment. And it is what our software does, taking into account the big data and that type of simulations. And all of that works with telemedicine. So doesn't matter where the physician is, the patient will receive the best optical parameters ever, every time. We proved it in our clinical trial, reducing 85%, reducing 50% or more of the pain in 85% of the patients in our clinical trial. We also showed a decrease of the inflammation by thermography, and connected with that, the increase of microcirculation. So in the spot, in the knee, in that case, because we were talking about osteoarthritis in the knee. And only to have an idea, we quantify dopamine in the urine of the patients, and we saw a huge increase in dopamine in the urine of the patient. So showing that it had a huge release of dopamine in the body. Right now, we use it in the real world with the real physicians and patients. We applied more than 14,000 doses of our photoceuticals in more than 1,300 of the patients, and they decreased 60%, more than 60% of the intensity of their pain during the treatment. So we have amazing results that are as good or even better of the best painkillers in the world right now. We do it using, as I told you before, a huge amount of data to calculate the precise dose for each patient. And we connect in an app, mobile app, in the cell phone of the therapist, and it access the cloud and receive and makes the download of the precise amount of light that should be used in the patient. And it connects with Bluetooth to the light aid, that is the device developed by Bright, and emits the right amount of light. So we balanced strong and intense optical parameters, intensity of light, but very well controlled to always be in the top of the dose response curve to have the best results. Don't matter the personal characteristics of the patient. Of course, we customized it for several types of pain. We have it customized for 60 types of pain right now, all musculoskeletal, but we are entering neuropathic pain, and also as a next step in the transcranial applications of fotobiomodulation too. Here, just to share a little bit of our really recent results. This paper, it's very fundamental, and I wrote with Mike, and it talks about the digitalization of fotobiomodulation. This order is a basic science that we demonstrate that the skin phototype have a huge difference in the applications. And here we show that doesn't matter if we use LEDs or lasers, we got the same result if we use the same optical parameters. This one is very interesting, and it's used in postoperative, immediate postoperative pain in the knee after arthroplasty. And we saw that the patients used much less of the morphine after in the pump, and they decreased the pain. So both good results, used less of morphine and got even better pain decrease. And that other, it's the same but for different type of analysis for postoperative. Here is a very new, brand new, that we used or customized photobiomodulation to osteoarthritis in the knee in a randomized double-blind pilot study. And that other very interesting that we made an evaluation with patients with lumbar pain in important health provider here in Brazil. And just to have a take-home message, we decreased the number of people going to the first care health provider. It decreased for an average of around 2 visits per week to no visit at all in that patient in the study. And in that other study here that we compare a placebo group with the treatment group, we saw people that had 20 years of pain in the knee caused by osteoarthritis that decreased their pain to a very low level of pain in only 2 weeks, in 5 sessions of photobiomodulation, when it is customized, and it worked for 85% of the people. So it's really important to make that customization. Just to conclude, these good results remained statistically significant for 4 weeks and remained for 8 weeks before it got, after the treatment, before it got equal to the placebo group. So just to conclude, what we are doing, it's much bigger than we presented now. We really believe that we can digitalize the way that all body produce their own remedies. So in a near future, we believe that we can stimulate the body to produce several types of medicines, internal medicines, endogenous medicines, doing that stimulation using light in a precise way. So that's my dream. And I don't know if Mike remembered it, but when I told him the first time that I had that dream, he told, absolutely, Marcelo, but that will take 100 years. And I hope it do not take 100 years to conclude that dream. And I hope we can work together to make it available for everyone in the world. Thank you very much. Now I believe that we can go for a conversation for more 15 minutes. Mike, would you like to, Mike or Paulo, would you like to start with some questions?
Yeah, I think knee osteoarthritis is a very good application of photobiomodulation because pain and inflammation, everybody knows that PBM is very good at reducing it. But the interesting question that nobody has really answered yet, can photobiomodulation stimulate regeneration of articular cartilage? Because it's known that, there are chondrocytes in cartilage producing new actual proteins, but it's not many of them, and they're not very active. So regenerating cartilage is a dream or a goal, especially in the knee. And it's possible that photobiomodulation can do it. I mean, people have shown that in vitro, PBM stimulates chondrocytes. That's been shown many times. Mm-hmm. But I don't think it's actually been shown in the knee yet. I guess you could do it with MRI imaging. I guess you could do it.
Yes. Actually, it's a very good point, because right now we just sign a contract to make a a clinical trial, a huge clinical trial, 250 patients, and 80 patients will make magnetic resonance to see it before and after. And the idea is that we are trying to find that type of regeneration in the cartilage. So it hopefully few months from now we can have previous results about that, and hopefully we can say we will be able to say to find some type of regeneration like that.
So yours is a home use device. The patients wear it at home according to the digital sort of controls that you've got. Is that right?
Actually, right now, we, as a business model, we do not do it as a home device, at least not all the time. It's stay with the physician, but as a next step, it can be done. It's just, it's more related to a business stuff than a technological difficulty.
So they receive the treatment every day?
Not necessarily. We saw that 1 or 2 times per week, we got amazing results. It's not necessary every day. And actually, we did some cases of everyday application, and the results were not as good as 2 times or 3 times maximum. So some way it's not just go there and make every day and it will work better. Probably there is some type of dosimetry that we can do for everyday application, but right now what we saw that parameters that we calculated, the best way is 2 or 3 times per week. 1 time per week, we got amazing results, almost as good as 2 times per week.
Right. That's interesting. And what wavelengths are you using?
850 nanometers.
Just one wavelength?
Just one wavelength.
Okay, yeah, 850 is fine. I mean, some people would combine that with red with 660, but it's not clear you need to do that. I mean, 850 is probably fine on its own.
Yes, actually, we are developing another wavelength that will be ready for the second trimester of next year, around June, that is using red light, but for a totally different application, for regeneration of wounds and things like that. So for pain, for inflammation in muscles, monochromatic stimulation we are seeing that have amazing results. I don't think it's necessary to have a mix of wavelengths. Somehow I believe that it can not only be ineffective in a way of improve, but somehow you can overload the mitochondria, I believe, with somehow I think it's got much more difficult to calculate the really precise optimal irradiation if you use 2 wavelengths. So maybe one day we can go in that direction, but not now. We have we need much more data to go in that direction. Mike, I would like to have your opinion about 2 things. One, would you like to say to us how photobiomodulation works around the world? I mean, you work at many years in the United States, you are in Europe, also you are visiting professor at South Africa, and literally you know everyone in the world that is working with photobiomodulation. Would you like to say a few words of the different ways photobiomodulation is accepted or not around the world?
Well, as I mentioned in my sort of historical overview, a lot of this came about by laser therapy. So laser therapists depending on where in the world you are, chiropractors, physical therapists, various sort of clinics, sports medicine, these sorts of things. But what you generally have is individuals who pride themselves on their skill with a laser. So yes. They say, I can pick the right wavelength, the right intensity, the right dose. And how much this is based on real hard science and how much it's just, obviously they've all got good experience treating people. So that's how they manage to carry on their practice.
Perfect.
So that's a sort of laser therapist. I mean, the other thing that's spreading around the world is home use devices. So there are literally hundreds of different LED devices available for purchase on the internet that you can use at home for all sorts of different conditions.
Yes.
Now, a lot of the manufacturers are not very accurate on specifying their parameters. The power density, the total power, the exact wavelengths. There's a lot of sort of, lack of accurate parameters around, which is unfortunate because that means a lot of people keep emailing me asking which device to buy because they're like baffled by this huge variety of devices available.
Yes. It makes me come to the next two questions. I will share my opinion and I will make the question. I really believe that to make photobiomodulation mainstream, we need to have the physicians together with it in order to make it much more scientific and not dependent of the operator. And one of the things that I believe and I presented here is the necessity to make it to make photobiomodulation works no matter the experience of the person who are applying. So that's the main reason my team and I work so hard in make the dosimetry available for the physicians. So my question is, why, in your opinion, why photobiomodulation was not mainstream up to today? And what could be done to make it mainstream?
Well, the reason it's not mainstream is the large companies that have the financial resources to carry out trials, your Pfizers and your Mercks and your Sanofis and all these huge multi-billion-dollar companies have not really found it an attractive business model. I mean, they could easily run a trial and show clinical efficacy. There's no problem in doing that. But then they would think, well, we're used to having pharmaceuticals that are prescribed on an ongoing basis. And it's difficult to see how they can make money from a photobiomodulation device. Are they going to sell it to the physicians? Are they going to rent it to them? Are they going to charge per treatment? I mean, it's not a clear business model for these huge companies.
Okay, great. One more time, I think we solved that part of the puzzle too, because we do not sell the device. We sell the application of the specific dosimetry, customized dosimetry, in the same way as the pharmaceutical companies sell the drug. So hopefully we can this model is a great investor around the world. So I really believe that they are seeing it the same as me. But I totally agree with you that we have a problem in that context, that as the big pharmaceutical companies, they have business models that allows them to grow and really invest in huge clinical trials and majorly in huge amounts of money for marketing. Only to have an idea, in the pharmaceutical companies, in average, 40% of the money goes for marketing and 30% for for R&D. So it's the price that is charged that's not connected with the cost to produce a medicine, but much more related for marketing and
Right, so. And yeah, I mean, that applies to laser companies as well. I mean, a lot of laser companies charge $30,000 for a laser that probably costs a couple of thousand to actually manufacture it. I mean,
yes, for sure. And I would like to ask you, I think we have more 5 minutes. If Paulo would like to bring us any question, or we can go on.
Yes. Yeah. I would like only to ask you both, the professor, about cancer patients and photobiomodulation can be harmful or not.
Yes, actually, it's a very good question. Right now, there was a taboo, a myth that photobiomodulation, you cannot use photobiomodulation at all in patients with cancer. There was a concern about to stimulate the growth of the tumor or things like that. But what we saw in the last years is the use of photobiomodulation in other parts of the body that has not the tumor, and it really helps for the patients to decrease the pain that many times are associated with the cancer by itself. Also, it's possible to use transcranially to make desensitization of the pain transcranially, or even in the dorsal root ganglions. So there are several possibilities to use photobiomodulation in patients with cancer. I'm not saying to use to decrease or to kill the cancer, but for the symptoms and conditions associated to the cancer. Also, the chemotherapy and radiotherapy induced neuropathies, photobiomodulation has amazing results. And of course, in mucositis for the patients after the irradiation of the head, photobiomodulation has really, really amazing results. So that's what comes in top of my mind. Mike, what do you think?
Well, we should not discount the possibility that photobiomodulation could actually treat cancer. I mean, as Marcelo correctly says, there's always been a taboo, so this has not really been studied. But, you know, there are a few papers that suggest that photobiomodulation can treat cancer. You know, there was one where cancer patients that got PBM for oral mucositis actually lived longer than those that didn't. And you could say, oh, well, you know, they were able to eat better because their mouth sores were decreased. There's other explanations, but it's known that photobiomodulation stimulates the immune system, and it's also becoming increasingly realized that the immune response against cancer is very, very important. So I would not completely discount the possibility that photobiomodulation can treat cancer. But it would be very difficult to organize a trial because people would be worried about the opposite effect. So.
Yes, for sure. And as we are seeing the increase of immunotherapies related for in oncology, photobiomodulation with its power of immunomodulation, probably it could be used directly to treat cancer, as Mike told, or even connected with other type of immunotherapies. So it would be very interesting. And as Mike told you, probably it would be a huge clinical trial and very difficult to make it, but it would be really, really amazing if it could be done and created medical evidence, scientific evidence for that type of use of photobiomodulation. For sure, it would be important for the world. I think we are in your time. I don't think we will be allowed to continue. For myself, I really enjoy that type of conversation. It's always amazing to be with Mike and with Paulo. It's really good to have both together, two good friends, very smart people from whom I learn too much. I learn a lot. But of course, unfortunately, we have to finish right now. But I would like to say one more time, thank you very much, Mike. It's always a pleasure to learn from you, and Paulo, your kindness to invite us. It was very, very good. I'm very grateful for you. Thank you very much.
Thank you very much, Marcelo. And thank you very much, Michael. And we have lunchtime now. We'll be back at 2:15. Hopefully we can all together for best learning in.
Bye-bye. Thank you.
Okay. Thank you for inviting me. Bye, everybody.
Everybody.